I've only just, oh God, that's fine.
Okay, speak now or forever hold your peace. We are recording, okay? And so look, the other thing I wanted to tell you about was the Clinicians for Choice launch. So just last week, I attended a launch of a national group calling themselves Clinicians for Choice. The launch was actually broadcast from New South Wales. Our colleague, Professor Kirsten Black and Deb Bateson, who many of you will know as the previous clinical lead at Family Planning New South Wales, were the hosts for this. Now, look, this is a direct copy, basically, of a campaign that was run in the UK called Doctors for Choice. And so I want you to have a look for a bit of fun at Doctors for Choice UK website, but not now because you're paying attention to me, but later. They are hysterical, but they're more than hysterical. They changed the mandate to delegislate and make more simple the prescription of early medical abortion. And so we saw them presenting at the VCNACC conference that Kirsten and I attended. So the VCNACC conference is International Federation of Abortion Providers, and they had their first one for 3 years, and this one was in Latvia. So for very many reasons, it was a fantastic and very emotionally charged place to be post the pandemic. There was a lot of learnings, and of course we were very proximal to the Ukraine, so there were a lot of learnings from there and a lot of sharings. But the big message that's coming out of the North America and Canada and the UK is that the pandemic was the catalyst for making delivery of medical abortion earlier, simpler, and with less testing and with less legislation. And it was brought in, particularly in the UK. Oh, here's Carolyn. It was brought in particularly in the UK as sort of a stopgap measure for during the pandemic, with a sunset clause where when the pandemic was over, you know, that mythology, when the pandemic is over, there will be a new world. So they were going to reverse it and bring it back to the way it used to be, which was full of lots of restrictions. 25,000 prescriptions later, they did a really good piece of evidence-based research and proved that the outcomes were as safe, as acceptable to the patients, and were associated with much earlier access to early medical abortion. So the average gestational age of women receiving the medications was 2 weeks earlier. So instead of 7.5 weeks, it was sitting at 5.5 to 6 weeks. That's phenomenal. They delivered 70% of them below 7 weeks. And so their complication rates went right down. So the evidence-based stuff was being presented to the United Kingdom, but that didn't tip it over. It was Doctors for Choice and their cover versions of some very, very funny ABBA songs, to which they have put the message that they really wanted to delegislate early medical abortion. So if you need a little bit of Christmas cheer, do watch those. Now, in Australia, we're trying to copy a kind of different approach that's not super academic, but encompasses consumers and social media and have a slightly different approach to lobby the governments, okay? Our state governments, to see if we can get a similar mandate. And so I'd encourage you to have a look at the Clinicians for Choice.
I'll put the link up.
You can put it up. So the first thing that we're doing is an open letter to the government. So the more signatures to that, the better. So that's a little bit more simple than the Senate inquiry submission. Yeah. And just at the time of the launch, we got a very generous offer from the originators of GetUp to help us with our social media. I think having attended the launch and realizing how pathetic we were at social media, they have felt that this is their social duty to help us, which is fantastic.
Oh.
So watch this space, do join, everyone can join. Just because we launched it in New South Wales, that was because they've got an election coming up, but it's going to be a national group. And we're deliberately choosing clinicians, not doctors. We want it to be more inclusive. Any comments about that?
Oh, I'll put them in.
Sarav put up.
That's
Saurav did-
Australian
Yeah,
Commissions
but
for
Sarav
Choice.
did the other one.
Oh, sorry.
Yeah,
I'm
he's
looking.
done the Doctors for Choice from Britain.
Oh,
And
sorry,
and
I'm
we've
looking
got,
at
so
the
we've
wrong
got, we've got
Oh,
them both
good.
there.
Oh,
Yeah.
good. Thanks, Sarav.
there. Now, during that advertorial, I think Carolyn has joined us. Has she? Yeah. Hello, Carolyn. Sorry to hear you were having hassles with transport. So if you would like to give us your weekly roundup.
Yeah, thanks so much, Patty, and thanks everyone for your patience. Yes, there were public transport disasters in Coburg today, but here I am. So thanks everyone for your patience. 1-800 My Options, I think suffice to say, I know that a lot of services have been really, really busy lately. 1-800 My Options is similarly busy. We've been having a look at the stats that we've had, and since August through to November, we've been averaging around about 76% more calls than an average year. So we are quite busy at the moment on the phones. The makeup of our callers has remained absolutely steady. So we're still somewhere between 70 to 75% of our callers are looking for medication abortion, which is really great to see that demand remains quite steady. Those people who are looking for medication abortion, we can often find a community provider for them locally. We've now gotten up to almost 600 providers on our GeoMap database. Of the ones that are on the GeoMap database, I think around about 85% of them are visible publicly. So that's really great. So we're getting more options out there for people that want to look for themselves. We've also had a really big increase, particularly since Roe versus Wade in the US, in our website hits, because obviously people are starting to look into abortion options a little bit more by themselves. So our website hits have skyrocketed by the thousands since the same time last year. So we're very, very busy. And what we're seeing right now is that the system is still struggling a little bit to be able to meet the demand of abortion seekers across the state. One of the bigger private clinics in the western suburbs is currently closed until further notice. And so that's making quite a big impact on service seekers in the West. It was the only surgical abortion provider in the western suburbs of Melbourne that was easy to access or possible to access for someone choosing abortion. And so pressure is happening across the other private providers in the eastern suburbs, as well as the public hospitals as well. A lot of people are choosing, if it's possible for them, to be able to travel rurally for a surgical abortion if they can actually get on those lists, which is quite an extraordinary situation, I have to say. So I know that I've been in touch with a lot of the people that are in this meeting already, but if I haven't, I might be getting in touch with you as well. We're looking at which clinics are closed over the Christmas New Year period so that we can start managing some of that demand across the system. We understand that everyone needs a break. It's been such a big couple of years. 2022 has been very, very busy. So please let us know if you are going to be closed. I'll pop my email in the chat here. You can also just get in touch with us through the 1-800 My Options website to let us know when you'll be taking a much deserved break so that we can make sure that we're directing our callers to alternative services in your area. Thanks, folks.
Thank you. Sorry.
Great. Thank you so much, Carolyn. Could I just tease out something you said there? Is the proportion of practitioners happy to go public, is that rising? The number, yeah.
Sorry, I was on mute there. Yeah, it absolutely is. We are finding it's less common for a practitioner to actually choose to be privately listed. So currently we've got actually, I think the number I gave you was a little bit inaccurate, but if you look on the public map, there's 516 visible there. And so we've started to target a little bit more some of the imaging services. It's one thing that we've found, particularly over the last 2 years. Getting an ultrasound has been really difficult for a lot of our callers, particularly low cost ones. So across the metro area, we've had a little bit of luck with some providers that are able to provide sub $100 pregnancy dating scan, which is a pretty big thing because they can be quite difficult to find. We're still looking for more rural ones though. So if any of our fabulous rural practitioners know a good ultrasound provider, please let me know so that we can get in touch with them to link our callers in when they're looking for that service.
Sure.
But yeah, more people willing to be publicly known and associated with sexual and reproductive health and abortion is really fabulous.
Yeah, great. And look, just a bit of a shout out back to you that really finding the map, the service map, really helpful in terms of having at the fingertips some numbers and some data to throw at any submissions or advocacy, you know, and it really helps. Because one of the things we always used to be saying was, well, there's not much data on abortion because it could be miscarriage, it could be abortion. We now have a lot of really good data. So thank you once again, it's really helpful. The other thing we put into the Senate inquiry was to copy the Victorian model of 1-800 My Options so that there's a federal push for that kind of a service in every state. So people are going to want to hear from you, Carolyn, I think. Any comments or questions for Carolyn before we move on? So we always have, we're now at that point where we do a little case study. And this case study we generated when we were up in Albury-Wodonga recently. And it's the kind of, it was presented by one of the nurses, but it's a really common question that we get asked, isn't it? You know, either during the workup of a patient or maybe a clinician reflecting later about whether they should change their practice around workup. And it's also a good teaching around the issues of safety and what we can do safely now. So I'm going to read out the script and just stop every now and again, and please chip in. There aren't any right and wrong answers. It's just a thing to think about. So a 24-year-old single female comes to your clinic. She's approximately 4 to 5 weeks pregnant by her last menstrual period, and she does report regular 28-day cycles. She's gravid of 2 paranaught. She's had one previous termination, which was a surgical termination, and she's keen to seek a medical abortion. She's A positive. She's got no significant history. So she comes to your clinic referred from the GP practice that knew about your clinic for an appointment regarding her unplanned pregnancy. She saw her own GP. So she comes to you on the 6th of the 9th. She saw her GP approximately 7 days prior and had all the tests ordered and the results received. So I'm now going to give you the results of the tests. So on the 31st of the 8th, so 7 days prior, her beta HCG was 214 and all of her other results were negative. So she's wanting an early medical abortion. She's booked for an ultrasound. Does anybody want to comment on the beta HCG result? What they think of it? Siobhan, you made a face.
Technology. I was just thinking if she's estimating that she's 5 or 6 weeks, did you say? It's quite
4 to 5.
Yeah. So it could be low, could be fine. I might want to repeat it in 2 days. See it double. But I'd also see what the ultrasound says as well.
When would
we
you
had one very similar a couple of weeks ago.
So when would you order the ultrasound for?
I thought you said it was already booked, but
I
I
said
would.
booked, but I didn't tell you when it was booked.
Oh.
So when do you want it booked? That's the.
Well, I'd probably chase the blood first and then do the ultrasound. But you know, I work once a week, so I kind of just organise things so that. So I'd probably have the blood.
What I'm getting at is when would you expect to see something in the uterus? So if it doubles every 2 days ish, and it's 214 on the 31st, you're seeing her 7 days later.
Mm.
So it should be up over 1,000. Yeah.
Yep.
So
Yep.
we could do an ultrasound now ish, but instead they wait another 3 weeks. So someone else, Erin has said over 1,000 to see something on the ultrasound. Yes, I agree, Erin. Where are you? I've lost you. Yeah. So, you know, it should have doubled up to over 1,000 by then. So you would expect to see something on a PV scan by then. Might not see a fetal heart, but you would expect to see a yolk sac. So yeah, we could do it sooner. So booked for an ultrasound on the 21st of the month. Oh, there's a dog.
That's a Siobhan's dog.
It's Siobhan's dog. Okay.
Oh, not Siobhan.
So that delay is possibly because that was the soonest they could get the ultrasound. Okay. But if you were working in a clinic where you had a scanner, you could put the scanner on 7 days after you'd had a result of 214, assuming that if it's doubling normally, you'll see something. So she had an ultrasound on the 21st of the 9th. Both trans-abdominal and trans-vaginal scans were performed. The gestational sac was reported as being normal, of normal architecture, with a mid-sac diameter of 18.2 millimeters. There was a yolk sac present. So there was a yolk sac seen. The embryo was not present. The uterus is anteverted, the cervix is closed, there was no adnexal masses or tenderness, and the conclusion was an intrauterine pregnancy of uncertain viability. Now, this happens very often because women are getting more and more menstrually aware, or whatever you want to call it, whatever the term for it is, and are getting earlier diagnosis, and that's what we want. So any comments on, I guess I'd throw out, you know, what do we do next? Can we do the MTOP now? Somebody's nodding. Erin's nodding. I'm nodding. Yeah, yeah. Anybody concerned at all? And again, there's no wrong answer. Anita, would you be happy? I'm staring at your lovely photo. Anita, are you there? Would you be happy to organise the MTOP now?
Sorry, Patty. Hang on a minute. Here I am. Now, sorry, can you please just repeat what were the bloods? And the scan showed a gestational sac of 18 millimeters, but no yolk sac or CRL.
No, it's a yolk sac.
Oh, yes, absolutely. Yolk sac, I'm in. Yes.
Yeah. So you don't want any more betas, do you?
No.
No. Okay. Yeah. So would everybody be in, or would others be a little bit concerned? So why I'm telling you this story is because you providers are now the experts in this area, okay? So you know where the zone of discrimination is with regard to an ultrasound, okay? You know that you would expect to see something at about 1,000. You also know that a yolk sac shows the presence of an intrauterine sac, okay? So this nurse took the ultrasound to the GP in the practice, who had become an early medical abortion provider, who said, we really need to repeat this because it might not be viable, and you can't do a medical abortion if it's not viable. So I just wanted to address that thought and see what people think. What do you think, Louise, about that?
This is really very timely. And it is
thought
something that we've grappled. And it's really interesting because it's even just now merging into the surgical termination space of, you know, miscarriages, and do they be booked into the choices clinic or into the gynae clinic for a D&C. So from our perspective, this person has a beta HCG, has an intrauterine pregnancy, and is able to have a medical abortion.
Yeah.
With no
Eric?
further. The only thing that I would say is that the question about doing a beta HCG at the time of mifepristone, because of the issue in terms of success, in terms of the person's story. So that's still a little bit, what's the word? There's still conversations about that, you know, having that second beta HCG at the time. We would have expected it to go on above the 1,000 at the time. So I'm curious about everybody's expertise around that, because that's something that has crept into our care, an extra beta HCG at time of mifepristone dispensing.
So, Erin, I saw an expression on your face, which might, I just wanted to explore that with you. What were you thinking?
Well, apologies for expression.
No, this is as close as I get to having human contact, Erin. I need it.
So it's the patient's requesting a termination of pregnancy. You've seen an intrauterine pregnancy with a yolk sac, so you can proceed with medical management. It's the intrauterine pregnancy is less than 63 days size pregnancy, and you want to try and give the medical management as promptly as possible, to ensure that it works well. Like I can't see why she couldn't have it, why she would need surgical. You could consider, particularly if you're going to be doing follow-up with beta HCGs to see that they trend down, you could consider a repeat with a check full blood count and iron studies opportunistically, and a STI screen if you haven't got that, when you prescribe the MS2 step, and then repeat the beta HCG for follow-up with an FBE to ensure that, all has gone well and that the medication has worked.
Apologies, Erin, if I've confused you. I'm totally in favour of this person having a medical abortion in the primary care services. My interest and curiosity is that I work in the surgical termination service at Bendigo Hospital, and we have some curiosity around some doctors saying that if somebody presents with an ultrasound at this stage, and that they chose to have a surgical abortion, so that's their choice, that if they've got an unviable pregnancy, whether or not they're allowed to have a surgical termination in a surgical terminations clinic versus having a D&C in a early pregnancy assessment service. So it's just very interesting. It's very topical for us here in Bendigo in terms of how many people you put on a surgical termination list. If you've only got a list of up to 7, 8 at the maximum, and you've got people who are booked in to have a surgical termination but have an unviable pregnancy, whether they get shunted off because you're waiting for someone who might be 11 weeks or 12 weeks, to come in the next day. So that's just a situation that we have here in Bendigo sometimes, because we only have a fortnightly surgical termination service, and for the other regional and rural staff, clinicians on here, sometimes you've got to, make a decision about who can come this week and who has to wait another fortnight. So it's, it's another reason why we need to get loud at the Senate inquiry in regards to surgical termination services at regional public hospitals and how often they should do them.
And it's really timely, Louise, because it's another, you're both making really compelling arguments about doing the procedure in a timely manner and doing it when the patient presents. And it's really another way of framing this is it's an intervention into the pregnancy, whether you define it as a medical abortion or a medical management of a miscarriage. And does it matter? No, it doesn't matter to the TGA. Who does it matter to? It matters to our patients that they come, they get a service on the day, and they don't get sucked into the iatrogenic vortex of over servicing and over investigating. And so what this part of the case study is slightly hyperfictionalized, because I like to do that to just make the point. But this poor patient went on, the GP wasn't quite sure what to do next, so rang the local hospital and got the level 2 ONG trainee, who said it could be a miscarriage, and that way we might be able to do her on our miscarriage list, Louise. But if it's a viable pregnancy, she'll have to go somewhere else, you know? So we're now 2 weeks after she first consulted you, and she has a scan, she has a repeat beta HCG on the 26th of the 9th. Remember, when you first met her, it was 214. It's now 53,100. And the wisdom that came back from the junior registrar was, that's not doubling appropriately. I want to see what it is in 2 days' time. At which point I start looking for a wall to bang my head on, because why would we do that? So the other learning for the hubs from this is, you are the experts. Don't keep thinking you have to ask someone at the big hospital whether your patient's allowed to have something. What you're doing is safe. There are huge trials overseas of early intervention. You don't have to wait till there's a fetal heartbeat. We know that. We don't really have to define whether it's a miscarriage or whether it is a medical abortion. But what we do have is a duty of care to deliver it in a timely manner. And the patient's experience is going to be less bleeding, less pain, less likely to have an incomplete. So look, I don't want to bore you with how many ultrasounds this poor woman had and how she was recommended to have a curette for a miscarriage. So she did go on to have a miscarriage, but she could have had an intervention and had the contraception of her choice some 3 to 4 weeks before she actually eventually had her curette. Anita, comment.
Yeah, really, I agree with you. And at the end of the day, I think it comes down to her choice, and that's what needs to be supported, because you don't know, well, you know, everyone's circumstances are different, but she might be in some situation of urgency due to travel, due to coercion, due to who knows what. Catherine's made a point about if the patient is paying a lot privately and finding out it's non-viable, they may be able to access free public hospital management. Again, I have always thrown that back to the patient and said, look, you know, it looks like a miscarriage, or we still probably need one more scan to determine that. But the criteria are, you know, it's 11 days or 14 days, depending on what the original scan shows. But you know, she can make that decision herself. I think that's important. And some, due to financial restraint or having that explained to them, are more comfortable going to EPAS. Some, if they want to have it done privately because that's right for them, I think that needs to be supported.
Any other comments or concerns? And, you know, sorry, you go.
I was just going to comment that I had a patient very similar to this, and she really wanted to believe that it was a miscarriage. So we chose for her that it was a miscarriage, and we were just completing it for her.
Yeah, yeah.
That's
So
important too.
that's a nice way to do it, instead of saying, let's wait and you have to prove that, you know. It probably was a miscarriage, you know, yeah. And look, this discussion really goes into quite a much bigger discussion about the way we manage early pregnancy issues. And one of the hopes I would have, Nafissa, is if we do get to the point where we have women's health clinics embedded in a lot of public hospitals, that we stop siloing this idea of miscarriages equals good girls over here and abortions basically equals stigma over here, you know, when we know that there's a huge crossover. And if we had early pregnancy assessment clinics that managed everything, you know, we're already in our EPAS clinic using mifepristone and misoprostol for miscarriage management. So we're using the same treatments as well, you know. So it's I think that's probably where we're going to go in the future. And we're buoyed on by the safety data from Britain, where they're dropping more and more tests. And that's a conversation for another day, Louise. I'm quite happy to do some little clinical update on what tests they're dropping, you know, and they're dropping beta HCGs like that and moving to a low sensitivity urine test. Yeah, instead of having to prove what was it on the day that we gave it, you know, because going through blood tests is another barrier to follow up, isn't it? Erin.
Just in regards to that beta HCG, we have a new registrar from another part of Victoria, and their service, tertiary service, is doing beta HCGs all the way through till negative post. Yeah,
Not needed.
that's what, you know, I would.
Yeah, so there's
aware
huge variation. Yeah.
Mm.
So the less we do, the more simple it will get. Yeah. So just aware of the time, and we'll move off the case study, but let's do a little bit more of an update on those kind of things early next year. This is a time where we just ask any of you, if you've got an update, you want to talk about a new service that's started or something that's happening in your region, please feel free to share it. And Sarab is saying there is a quick presentation from the Orient study team as well. I wasn't aware of that, Sarab. I'm really sorry. Yeah, so is that Jess? Who's
I'm not sure.
Hello, yes it is, but feel free to continue. I'm here, just happy to wait until the meeting's finished. So
okay, Jess, look, we'll just have a bit of a regional roundup first, okay?
Absolutely, sounds perfect.
Sorry, I wasn't aware you were here tonight.
Oh, that's okay, thanks.
Anyone else? How are things going in Ballarat?
Dan was here.
Yeah, Dan was here. I saw Dan's photo. And so was
Natasha said she had to go.
Oh, Natasha had to go. Is Dan still here? Because we wanted to say congratulations for getting this service up and running.
No. Looks like Dan's not there.
Maybe Dan's had to go too. But anyway, congratulations. They've got a surgical service up and running fortnightly, and they're also doing weekly MTOP service at Ballarat. Never thought it would happen. So that's fantastic. Anyone else? Oh, Heather's got her hand up. Yeah, hi, Heather.
Hi, Kath and Patty. Just wanting to share that I don't know whether a couple of meetings ago, perhaps, or last meeting, we talked about the migrant farm workers accessing our sexual health service. And last week I was contacted by an HR worker at one of the farms in our local area who wanted a health promotion event. So one of our GPs, Sophie, and nurse Amy are going out in a couple of weeks on a Sunday afternoon to prevent sexual health, safe sex and contraception options available in the area. So we're really pleased that they reached out to us and made that contact. And that was one farm, and she had 35 women.
Wow.
So there are probably 2 or 3 other farms that have similar numbers of women. So we're really pleased to be able to work on that. So just thought I'd share with you on that one, and look forward to seeing you tomorrow.
Yeah, can you turn the beds down for us?
Sure, I see you haven't left
Order a
yet.
helicopter.
I'll
We're a
try.
bit late leaving, but anyway, we're really looking forward to going down to Gippsland again. That's
Thank you.
really interesting, because we've been wondering how to get in contact. We're seeing quite a few patients from fruit picking, and we're wanting to make some inroads, so we can have a chat about that too.
Yeah, that'll be great. Okay.
Lou wants to say something.
We want Lou to say something.
So Rachel Lee's here on too, so that's wonderful. So we're very busy. I think we did some statistics for a presentation early on, and we counted up, we've done over 800 EMAs since we first started, and certainly have had an increase this year. And that's wonderful because we've got 4 GPs who are prescribing now. So, and we did have a Friday that there was no doctor, and now we've got a doctor working half a day Friday. So we've got 5 days a week availability, which is fantastic. And the other, I suppose, news is we're starting to, I suppose, what's the word? Structure our IUD insertion clinics, because now I've completed my training through Sexual Health Victoria and starting to provide IUDs, and we've got 2 other GPs. So that's fantastic. And just to a little bit of a side, we're actually part of the Safer Care Victoria heavy menstrual bleeding project, looking at 10,000 lives and looking at access to options in terms of people with heavy menstrual bleeding. And we just felt that was really important for us here in Bendigo as a hub, particularly because we get a lot of referrals from GPs within our within Bendigo, but also people coming in from other towns, particularly rural towns. So that'll be interesting in doing some of those data and PDSA type of projects. And I'm not quite sure if everybody knows, but there was actually an expression of interest for some funding to be a Centre of Excellence for Endometriosis. There was a bit of money through the PHN, so we've applied for some more money. So we're trying to do a lot of things, I think, and probably the critical thing is that we're running out of space for our clinicians and our nurses, etc. So often you want to provide all these services, but you've actually got to have rooms to put staff in and to have an adequately resourced, kind of sexual health hub. But yeah, all good. And Marianne's an apology tonight. She says to say hello, everybody.
And you mentioned Rachel was here too. Rachel, would you like to introduce yourself?
Sure. Hi. Sorry, my husband's was lately called on call unexpectedly, so it's like mayhem in my house. So apologies. I've been on crowd control. Hi, I'm Rachel. I'm a GP in Bendigo at the Community Health Service there. But my main role actually is in training GP registrars involved with the training program. So. But yes, so it was interesting to hear all that stuff earlier. I was thinking about that from the training perspective and how we could be involved in that as well.
Yeah.
So
and how often are you at Bendigo Health?
Mondays, so 1 day a week.
Yeah, that's what I thought. Yeah, so good to hear. Yeah.
Thank you.
Anybody else like to tell us something from their area?
As Anita's had to go.
And Anita's apology has to go. See you next year. So I think, Jess, the floor is yours now.
Perfect. Thanks so much, Patty. It's really lovely to see you all here. Thank you for having me. It's a lot of familiar faces from Sphere and Coalition and even uni, I'm Nafisa, so lovely to see you all. I'm just going to quickly share my screen. Just got a 2-minute presentation. All right, so, sorry, a bit slow. Is that all okay? Can you see the slides? Perfect. So good evening, everyone. So I'm Jess Moulton and I'm part of the Orient study. And I'm here today on behalf of Professor Danielle Matzer I prepared a very brief presentation to tell you about the Orient study, which we're currently recruiting for. Sorry, very slow internet today. So we know that women living in rural, regional and remote areas of Australia have a greater burden of unintended pregnancy, and long-acting reversible contraception and medical abortion can be effectively provided through primary care, as we've been discussing today. However, only around 11% of women are using a LARC, and only 10% of GPs are registered prescribers of MS2-step, and the majority of these are actually practicing in urban areas. So the Orient study was developed to address these 2 critical gaps, with which this group is very familiar with. So that of rural and regional access to contraception and abortion care, and also rural workforce issues around scope of practice. So we aim to test the effectiveness and cost effectiveness of a nurse-led model of care in general practice to increase access to LARC and medical abortion in rural and regional areas. So to support implementation of the model of care, we've developed a set of capacity building and support activities that will be delivered through online approaches. So the first activity is free online training on implant insertions and removals, and also medical abortion care for both GPs and nurses. And there'll also be kind of a broader module which is on kind of medical abortion and contraception more broadly. Each practice will also receive a 1-hour educational outreach session, which is co-facilitated by GP and nurse clinical opinion leaders. And it's also modelled on the successful approach adopted by the National Prescribing Service. And in these sessions, practices will discuss implementation strategies for delivery of the nurse-led model that we're hoping, or we will be tailoring to each practice setting, because we know that not one rural and regional general practice is the same. And finally, through engagement with the AusCAPS network, clinicians will be able to share clinical and experiential knowledge to aid implementation of LARC and medical abortion services. And there'll also be the opportunity for participants to obtain CPD points and also remuneration for their time. So here's a little kind of flyer that we have been posting a little bit on Facebook. So we're now recruiting general practices for the study, with our eligibility criteria being that the practice must be located in rural or regional Australia and have at least 2 GPs, a practice nurse and a practice manager keen to take part in the study. So I'd love to hear from you if you're interested and think you might be eligible, or if anyone from your networks may be interested. And yeah, we'd be really grateful if you're able to share this opportunity among any of your interested networks. So we've got a QR code there as well. And I also have on the last slide if you'd like to kind of find out more. And I'll also post my email address and also the trial information in the chat afterwards as well. So I'll just conclude here, but also just acknowledge the MIFF for funding this study, and also our collaborators have really been integral in undertaking this work. And also thanking, there's even a few people here today that have been really instrumental in developing the model as well. So thank you all for your help. And thank you so much for your time. So QR code there again, and I'll also post a few things in the chat as well. So thank you again for having me. We really appreciate the time. We know how it's yeah, really important meeting, and really interesting to also hear what's kind of happening in practice and in the community. So thank you.
Thank you.
Thank you, Jess. Yeah, thanks for that information about the Orient study. I also just wanted to highlight that my understanding is that the sexual and reproductive health hubs are not eligible for participation, unfortunately, in the Orient study. When I've investigated it, and I'm assuming it hasn't changed, that it's just it is private GP practices that are eligible.
Yeah, so we've been this has been a really tricky thing we've kind of been working out. We have kind of, I suppose, been advocating for if there is any kind of Medicare billing, because that's how the outcomes are being measured. So that will be why we would need to have the billing. However, community services that do have Medicare billing may still be eligible. So I'd say to them, yeah, if there is, that's kind of we've kind of been able to negotiate that. So that would still kind of work with our exec team. So if there's anyone you think that might be within that category, that could definitely work.
Oh, okay. Well, perhaps what I could do is send out the flyer again to the nurses and nurse practitioners at the hubs, and you can work out if they are eligible.
Oh, thanks, Kath. That would be awesome.
Yeah, the point we would make is that the majority of the work we're doing is with community hubs, and if they're going to be doubled, you know, they're the groups that are going to model the nurse-led models, you know.
Absolutely.
Yeah. And
yeah,
it's a bit of a shame if they're not involved. Well, it's a big shame. Yeah.
Yeah.
And
thank you.
So has that been, that revised criteria, is that clear when you go into to register your interest? So if the team went in and registered their interest, would it have been updated?
There's not, I suppose, because there is so many kind of nuances to you know, working out how the funding model would work at the practice or the community centre. There's no, I guess, eligibility criteria on that online, and it could be something that, you know, if the person expresses interest, we'll either give them a call to chat about the questions, or also send an email, and they can kind of fill that out in their own time. But agree, yeah, if there's, I'll talk to the team and see whether they may be able to kind of provide a bit more clarity online as well.
Okay, thank you.
Thanks so
And
much.
just aware that, you know, we are known as ferocious timekeepers, and we're revving the car as we speak. We're going to jump into it. So thank you all for your attention. Now, I don't think we've got a date for next year, but we will put out a save the date very soon. Is that right, Saurabh? There isn't a date finalized yet?
Yep, we don't have one yet.
No. So look, I wish everybody a safe and happy festive season, and we'll see you all in the new year. Except we'll see you tomorrow, Heather. Bye.
And Amy too.
And Amy, yeah. Bye.
Bye.